On behalf of Dr. Guy Mintz and myself, we would like to welcome you to the National Lipid Association's The Lipid Panel. My name is Dr. Merle Meyerson. I'm a cardiologist and lipid specialist. The Lipid Panel was conceived to be a lipid clinic conference similar to educational conferences held at academic medical institutions. For both those who have these conferences and for those who do not have in-house conferences and colleagues, the Lipid Panel is a great way to review diagnostic approaches, how to interpret clinical findings and generate therapeutic strategies, find the most up-to-date information, and come together with those in the lipid and cardiometabolic community. The Lipid Panel offers CME and is held on the last Tuesday of each month, except December, July, and August. We tape all sessions and they're available for viewing on the NLA website. A few notes about tonight's session. The topic of the discussion is weight loss drugs with a focus on the GLP-1 receptor agonists. Since these drugs began being used for weight loss, there have been many clinical trials, new FDA indications, and concerns about reimbursement and supply, and questions about long-term safety. Tonight, we will focus on patient management based on our case, but also touch on some of the other very important issues. After the case presentation and panelist discussion, we'll have a question and answer period. We'll close out the formal program at the 1 hour mark, but we may have an option to extend it by about 15 minutes if questions are still coming in. Note that CME credit will only pertain to the first 60 minutes. I'd like to introduce our panelists. Karen Aspry is a clinical cardiologist and lipidologist. She holds an undergraduate and master's degree in nutrition science. She's practiced in her native Rhode Island since 2005 and is an associate professor of medicine at Brown University's Alpert School of Medicine, where she directs the lipid and prevention program for the Lifespan Cardiovascular Institute in Providence. She's also the associate director of the Lifespan Ornish Cardiac Rehab Program. Ben Brink is a cardiology fellow at Rhode Island Hospital, Brown University, and he is very interested in comprehensive preventive cardiology and cardiometabolic disease and enjoys teaching and counseling patients on healthy eating, weight loss strategy, and lifestyle modification. Dr. Yehuda Handelsman is an endocrinologist in private practice and medical director and principal investigator of the Metabolic Institute of America. He's on many professional advisory boards and is nationally recognized authority on diabetes, lipids, obesity, and its complications. Don Wilson is a pediatric endocrinologist and lipidologist. Dr. Wilson has devoted over 20 years of his career to cardiovascular health and risk prevention in children and adolescents. Currently, he serves as the endowed chair of the Pediatric Cardiovascular Health and Risk Prevention Program at Cook Children's Medical Center in Fort Worth, Texas. So with that, I'm going to turn this over to our moderator, Dr. Karen Aspry.
I believe Karen is muted.
This is a really, really important topic, and I want to thank Merle for her introductions for myself and Ben, Dr. Brink, and the panel. I just wanted to frame, the problem of obesity. So you can go to the next slide there, Mandy, and really have us really understand and really the impact of a BMI greater than 30 in the U.S. here. The prevalence has risen since the late 70s. As you know, it's now at 41% of U.S. adults, 20% of American youth. Large disparities. Obesity, a BMI greater than 30, is really more common among poor and underserved groups and many ethnic minorities, as you know. It is based on global burden of disease and U.S. burden of disease estimates, the fourth leading cause of death, just having the BMI of greater than 30. However, if you count diet as a cause, it becomes the number one cause of death mediated via cardiometabolic diseases and all of these risk factors that you can see. And it really has been linked temporarily to increased intake of added sugars in the population, which, began in the late 70s. The economic burden and why so many both, government agencies and industry and clinicians are interested in tackling this is the economic burden is a staggering almost $366 billion US dollars currently, and that includes direct and indirect costs. So we really need to look at all of the solutions, and GLP-1 agonists have kind of risen to the top here. So with that, I'm going to introduce Ben Brink again and have him present some of the background data, some of the science around this important drug class. Next slide. We're going to start with a case.
Thank you, Dr. Aspry. So we're going to start with this case. We have a 79-year-old woman who's been seen in the lipid clinic for the past year. She was originally referred for severe combined hyperlipidemia and some statin side effects. Today's visit is her 5th visit in lipid clinic, and we'll show a slide momentarily about her lipid progression. But at this point, we've already introduced rosuvastatin. We've up-titrated it successfully without side effects, and she's been started on semaglutide by her primary care provider. She was tolerating this medication well, with her main side effect being a pretty significant constipation, having about 2 bowel movements a day. In prior visits, she had mentioned that her physical activity was not great, and she noted, though, that her food cravings and portion sizes had decreased significantly since starting the semaglutide. Her past medical history, you can see here, is significant for uncontrolled diabetes, an elevated BMI of greater than 40, combined hyperlipidemia with an elevated total cholesterol greater than 360, triglycerides above 900 with a normal LDL, more consistent with the type 3 pattern. She had this statin intolerance in the past, but it was reported to be vague symptoms without myositis or liver injury, and she also had hypertension. She was premenopausal and had no adverse pregnancy outcomes and had suffered from depression, partially due to her obesity, and she had reported a history of overeating. As you can see here, her medications included irbesartan, hydrochlorothiazide, metoprolol, insulin, metformin, rosuvastatin, sertraline, a progesterone IUD, and semaglutide. In terms of her physical exam, was overall unremarkable, except for an elevated BMI at 41. Next slide, please. So looking back through her labs, when you see she's not on any statin all the way on the left, you can see that she has a combined severe hyperlipidemia with this elevated total cholesterol and elevated triglycerides with a low HDL and a high non-LDL. After that, we ended up checking, and at this point, her hemoglobin A1C was 9.8, suggesting her diabetes was not well controlled. Later on, we checked her particle number, which, as you can see here in March of 2023, her cholesterol at this point, she had been started on rosuvastatin 5, and her cholesterol had come down, but you can see that her LDL particle number was still very elevated at over 2,000, and specifically her small LDL particle was significantly elevated, greater than 1,000. She was slowly titrated up on rosuvastatin, up to rosuvastatin 40, and had also been placed on semaglutide. It's hard to be able to separate those two. It was not a true study, but more of a real world scenario. At this point, you can see in September of 2023, the change in her cholesterol. As you can see, her total cholesterol now in the normal range at 123. Triglycerides still elevated in the 340s, but significantly improved, with an A1C improving down to 8, and our LDL particle number significantly decreased from greater than 2,000 down to the 900s, and a small LDL particle from greater than 1,000 to now in the 300s. She also reported a newfound freedom from food and started to notice that she was losing weight. As you can see here, she went from 256 down to 241, about 15 pounds. And her glycemic control also improved, with a hemoglobin A1C dropping from 9.2 down to 7.3. So at this point, I want to just take a quick moment to review the GLP receptor agonist timeline. Amanda, if you can go to the next slide, please. So this kind of started in 1964, when it was noted that oral glucose introduced a greater insulin response than IV glucose, which later led to the discovery of these gastrointestinal hormones, now called incretins, and in particular GLP-1 in 1987. This led to the production of exenatide in 2005, liraglutide in 2010, deglutide in 2014, and then semaglutide, which we'll be focusing on mostly here, in 2017. Next slide, please. So the GLP-1 receptor agonists were originally targeted for diabetes management and increased insulin release, but researchers began to notice that it was having additional impacts on the body. In particular, for the brain, we saw a decrease in appetite, an increase in satiety. We also saw that there was a decrease in blood pressure, increase in natriuresis, increase in glycogen synthesis and glucose oxidation, an increase in lipolysis and glucose uptake, a decrease in hepatic glucose production, and this slowing or gastric emptying and decreased GI motility. So next slide, please. So in 2021, it was shown that semaglutide with patients with a BMI of greater than 30 or 27 and higher with either hypertension, hyperlipidemia, OSA, or cardiovascular disease had a significant change in body weight at 68 weeks when taken semaglutide versus placebo. As you can see here, there was a 14.9% change in body weight for the semaglutide group, or about 15.3 kilograms, compared to 2.4 in the placebo group. And I want to point out on the right-hand side here that almost 35% lost actually 20% or more of their body weight. Next slide, please. So cardiologists first started to notice the GLP-1 receptor agonists in 2016, and this was after the SUSTAIN-6 trial, when there was a change in cardiovascular outcomes. In this trial, there were over 3,000 patients that were either 50 years or older with diabetes and established cardiovascular disease that was defined as either previous MI, cerebral vascular or peripheral vascular disease, or if they had chronic heart failure or CKD stage 3 or higher. At this point, the primary composite outcome was first occurrence of cardiovascular death, non-fatal MI, or non-fatal stroke. And as you can see, the primary outcome here occurred in about 108 patients, or 6.6% in the semaglutide group versus 8.9% in the placebo group, with an absolute risk reduction of a 2.3 and a number needed to treat of 43. Now, this largest decrease is what we saw in actually non-fatal stroke. And as you can see here on the right, not a change, a statistical change, but a trend for non-fatal MI. Next slide. And you can see here again, death from cardiovascular cause, it did not cross the statistical significance. So at this point, it was the largestly decreased in the non-fatal stroke. Next slide. So then in 2023, the SELECT trial was published. This was about 17,000 patients. They were 45 years and older with a BMI of greater than 27, again with established cardiovascular disease as a prior MI, prior stroke, or symptomatic peripheral artery disease, But in these individuals, they did not have diabetes. So in the prior study, they did. In this one, they did not. You saw here that they were started on semaglutide and slowly titrated up to 2.5 or on placebo. The primary outcome here was cardiovascular death, non-fatal MI, or stroke. The events occurred in 6.5% for the semaglutide group versus 8% in the placebo group, showing an absolute risk reduction of 1.5 and a number needed to treat of 66. And I'm going to point out here on the right-hand side that it interestingly showed a decrease in all-cause mortality. And then they were able to extend semaglutide further into the heart failure with preserved ejection fraction population. Next slide, please. So this was the STEP-HF and the STEP-HF diabetes studies. And this you can see here is a meta-analysis. And in this, it was a primary outcome. The primary outcome was the change in the Kansas City Cardiomyopathy Questionnaire Clinical Summary, or the KCCQ-SCC, with a score ranging from 0 to 100, with higher scores indicating fewer symptoms and fewer physical limitations. And as you can see, those taking semaglutide had a 16 score improvement compared to placebo that had an 8.7 score improvement, with a significant driver being the change in the 6-minute walk test. Next slide. So this was kind of a quick whirlwind going through of the various studies that have been come out on GLP-1 receptor agonists. But to summarize here, we've seen that GLP-1 receptor agonists have decreased appetite, decreased body weight, decreased hepatic steatosis and circulating lipids, decreased albuminuria, decreased blood pressure and inflammation, and also increased exercise capacity. And a lot of patients have noted an improved psychosocial factor, that they felt freed from food, that they were now able to kind of take on these lifestyle changes and were able to have a higher sense of self as they started noticing that they were losing their weight. So at this point, I want to hand it back to Dr. Aspry and our panelists to take it from here.
Thank you, Ben, for that whirlwind tour of all these major clinical trials in the last, 8 or so years. And I think it shows that this class of drug really is, at this point, has some evidence behind it in terms of health benefits. Next slide, please. So at this point, we want to open Dr. Meyerson and all of us, we want to open this up to the audience and the panelists to really sort of talk about some of the questions around the use of this class of drug, as far as coverage and who should receive it, and prescribers, adverse effects, the length of treatment, when should these be considered in terms of age, and the costs per quality adjusted life year saved. And other adjunctive therapies in terms of lifestyle. And then, really also what's equitable coverage for this, given the known disparities in obesity, which are driven in large part by upstream social determinants. So, with that, we really want this to be a sort of a robust discussion and have the panelists and or the audience jump in and ask some questions here. I'm going to see if there's any questions. I don't see anybody has entered anything into the chat. And so I ask, our panelists, Dr. Handelsman and Dr. Wilson, if you want to start this off.
Sure. I think we'll start. She's a premenopausal woman, age 49. She's been struggling with weight for a long time. Regretfully, though, she gets constipation, and from what I understand, quite severe, which is a known side effect of semaglutide. Yeah. It's not a frequent side effect, but it can really be very uncomfortable when it is there. She did lose about 15 pounds, So she's not in your 20%, nor in your 15%, but I think we should give her some more time to do that. She has a nice improvement in her weight. She has a reasonable improvement in her A1C. Interestingly enough, her triglyceride continued to be quite high, and one needs to see, should she be somebody who is a candidate, let's say, for omega-3, specifically the EPA. She may have enough risk factors and diabetes to justify getting EPA as an added medication. Clearly, Karen, you have your background in nutrition, and she definitely needs to get a lot of more information about nutrition. Don, what do you think?
No, I think nutrition is obviously the cornerstone of everything that we do, children included. And there's a question here about should obese teens be treated. We'll be talking about this just a little bit later, but the answer is yeah. I mean, they've been approved now for children 12 and above. Now the question sort of becomes affordability and availability of these drugs. So I like the approach in terms of talking about the science, because that's what drives us to help make decisions. I don't think most of our patients, particularly children, can understand the science of this, but they're looking for short-term gains. I'm interested in, maybe perhaps someone can comment on this. You know, Karen talks very nicely about this patient being now motivated after they lost weight with regard to adhering to lifestyle issues. I don't know if that's true in many children or not. It's just probably the developmental stage. Certainly, embrace weight loss.
Yeah, I think, speaking of, first I want to bring up a couple of slides here, Mandy. So if you could pull up on your deck slide number 18, really focusing on what Dr. Handelsman said, down to 18 towards the end of the deck there. You can go down further right there. Nope, back up right there. So, this whole concept, which the ICER analysis panel did recommend that, lifestyle be a sort of adjunctive therapy with these agents. This is a sort of model that Dari Mazafarian from Tufts just sort of put an editorial in JAMA on in a sort of model and how to conceive of the use of these therapies rather than just handing them this drug, but have some kind of lifestyle programming involved, including, as you know, food as medicine has sort of emerged as a sort of new paradigm, if you will. So we're talking about nutritionally tailored groceries, meals, or produce prescriptions for individuals, in addition to culinary education and recipes. So they would have a period of time where they would get these foods and access to these foods via, produce prescription cards or groceries if they are able to make their own meals, and learn how to actually cook healthy meals. And so, they're talking about an initial therapy for 12 to 18 months to achieve weight loss, and then booster periods as needed over time, because it's going to be very variable and it needs to be individualized. So you can see from the bottom, there will be people who will, take this drug for a period of time and do well and not need boosting, and others that will. So this is something, now whether obviously the payers are going to recommend this remains to be seen. But I think all of us realize the importance of healthy nutrition and diet. And I think once patients get motivated and they see the benefits, there may be more sort of up for this. And then back one more slide there to back one slide there, Mandy. So about children and teens, I should say. Don, you were talking about this, and tell us about this data about semaglutide in teen population here. I think you sent this slide, and we're very interested in what the pediatricians think about this drug and what the guidelines are saying.
Well, for many years, and still to a large extent, the American Academy of Pediatrics and others involved in pediatric healthcare, particularly teens, have advocated lifestyle. And we obviously know that that's the underpinnings of this particular disorder, metabolic syndrome, if you will, type 2 diabetes mellitus. On the other hand, there's been a great deal of frustration because our success rate with that has been limited. Clearly we all have children and families who embrace it and do a great job, and we're all excited, but the vast majority of children don't achieve these kind of milestones. And so in the more recent 2023 statement from the American Academy of Pediatrics, they've now moved drug therapy, meaning GLP-1s, and bariatric surgery to the front of the line. So they clearly recognize that there's a category of children who have excessive BMI that it's going to be difficult, if not impossible, to get them turned around. So they've kind of moved that and kind of approved, if you will, using a combination of therapy, including lifestyle management, and encouraging a healthy lifestyle throughout their entire life, but moving those drugs up the front. Now, I don't know whether that's the right thing to do or not. The criticism is always when you give someone kind of an easy way out, if you will, then they really don't pay much attention to that. I don't know if that's true in the adult world or not. I will tell you that, and I think Ben mentioned this in your patient, the kids who have been on this drug and lost significant weight clearly have a change in attitude. I mean, clearly they seem to be much more self-reliant and more affable because a lot of these kids are suffering from not only depression, but they're jeered and bullied by their colleagues. And so we have a mental health specialist that works with us in our clinic because we try to scout these out and prevent these from occurring. But unfortunately, it takes a big toll on these families.
I'd like to address some aspect of that. First, GLP-1 approval for kids, and again, Don, correct me if I'm wrong. I think liraglutide was already approved a while ago. It's just a daily injection, and the loss of weight was not that much, so it didn't really pick up in the younger world. But it's very interesting to see that the impact in terms of weight, based on the slide that we just see from Don, is very similar to what we have seen in adult. It's a very similar weight loss, and that's quite encouraging. As a point, these drugs were approved for chronic use. If we take the position that obesity is a disease, and some of us do, actually many of us do, the AMA endorsed this position, the CMS now endorsing this position, then what we are seeing, is that really we may need to use a drug for many years. We do know for sure, you start the drug, you regain the medication, the weight, and that's something very important. Somebody online have been asking about what was the drop rate of semaglutide in the 20.
Yeah, I just saw that question.
Yeah, it just runs around 4%. It's in most of the semaglutide. Tirzepatide, that's the other form, it's about 5%, but it's very, side effect is up to 20-25%, but dropout was just about 3.84%. Another question regarding they talk about there are 3 versions of the particular medication. Realistically, there are 2 versions. There is injectable and there is an oral. The injectable is semaglutide for diabetes under the name that everybody is familiar with, right? This is the weight loss drug, but it's really a diabetes drug, the Ozempic. It's for diabetes. It's not for weight loss. The drug for weight loss is called Wegovy, and it's just the same semaglutide. It's also injectable. And what we are saying was Wegovy, there's slightly difference in dose. In Ozempic, it's from 1 milligram to 2 milligram. In Wegovy, it is from 1 to 1.7 to then 2.4. But that's kind of the main difference. Of point, people lose more weight when they don't have diabetes, when they are on semaglutide. in all these drugs, actually. There is more weight loss when the patient does not have diabetes. Lastly, the oral form, it's only for diabetes. It does have some weight loss, but not much. When we look at its potency, the max dose for the Rybelsus is 14 milligrams, and it's kind of equivalent to a 0.5 of the injectable semaglutide, just to give a perspective.
Yeah, I think the data really do show that semaglutide seems to, be superior to the others in terms of obviously side effect profile, but also efficacy. And so it has emerged as the drug that is now sort of been first to be, kind of first choice of providers and clinicians and patients as they read about these drugs on the internet. So that's interesting how that's changed over a short period of time.
And the study in adolescents comparable to this with liraglutide was about a 6% change in BMI over the course of the study. And this one about a 16%, but
yeah,
Dr. Handelsman's correct. I mean, this looks almost parallel to what you showed in terms of the adult responses. And side effect profile seems to be very similar to what you see in adults. Not all children can tolerate this drug, but they're much more likely than in the old days when we're trying to get daily dosing, because that's all we had. They're much more likely to be amenable to treatment if you're talking about a weekly injection.
And somebody also wanted to know some of the side effect profile. What we are saying in general that in around the 0.5%, we see nausea, that it's about 10 to 15%. We can see vomiting up to, practically all side effects, by the way, are gastrointestinal. And you can see up, about 6-7% vomiting, about 4-5% constipation, about 7% diarrhea. That's kind of what we're seeing with the drug. We go to 1 milligram. Now we can go with nausea up to about 20%, vomiting 8 to 9%. Again, diarrhea stays around 7%, and constipation will. That's the majority. Rarely there is pancreatitis. This is very rare. It's part of the whole class. And because part of the way the drug works, it slows down the GI tract, especially gastric emptying, and that may also cause some effect on the pancreatic tract. There's some question about cholecystitis. There's some questions about stones. But that's very, very rare. But if somebody gets pancreatitis from GLP-1, don't re-challenge with any other drug. It will happen again.
Yeah. So, Mandy, could you put that slide up? Is 14 just to summarize what Dr. Handelsman said there on these side effects, so everyone has a good sense of what they can counsel patients on in this. And so when we say common, Dr. Handelsman, we're talking about percentages of what would you say, 5% and then much less, or is it
no, much less from what you're saying on the uncommon.
Yeah,
but pancreatitis is quite rare. It doesn't get percentage. In studies it was like 3-4 versus 2-1. It was really very remote and no different than placebo typically in studies. Only post-marketing that we got that.
Yes.
Gallstone or cholecystitis are now being quoted for about 1 to 1.5%, if that can happen to that. Acute kidney injury, it's an important side effect that takes its place from history. So when exenatide, the first form of GLP-1, was approved in April of 2005, exenatide is cleared partially by the kidney. And that's where the FDA put a warning and started to keep that warning to all the other GLP-1. But a drug like semaglutide or liraglutide are not being metabolized by the kidneys, they're not being metabolized by the liver, they're metabolized in the periphery and not anywhere else. So the thing to worry is that if people get diarrhea and vomiting, and they get volume depleted, they can get acute kidney injury. So this is kind of a round and about the way. Just make sure your patient get it to tell them to drink a lot.
Right. So,
and I think it's important to point out the black box warning there that any patients with personal or family history of medullary thyroid cancer or multiple endocrine neoplasia type 2, should not be offered these drugs. But these are the side effects that patients are going to have. This particular patient was saying when she saw me, she was having bowel movements roughly twice per week. And, that's obviously not a healthy bowel. And so you wonder what the downstream effects of that are going to be. We don't know at this point.
Right. Well, that brings up, Dr. Aspry, that brings up a good point, because these doses are higher than previous doses used for diabetes. So what is the concern for long-term use, especially in children? You're blocking, or agonizing these receptor systems for many hormones. Dr. Handelsman, do you have any concerns that we need post-marketing information and what will happen, especially as you said, they're going to be on them for life?
I cannot tell you that I don't have a concern on a drug that I don't have 30 years of data on, but we do have almost 20 years of data on the GLP-1 class. And really not much has come up beyond what we are talking about. We have not seen that. So I don't know how many patients have been sticking on that for a long time. But I had patients that have been on Victoza on liraglutide, moving to semaglutide for near 10 years now. And I have not seen this kind of a problem. We have max impact on weight loss, usually occurs by 9 months. And that's when they stabilize. In terms of other aspects, every day with these drugs, we find new stuff coming up. And right now, I mentioned exenatide before. There is a similar drug to exenatide that's called lixisenatide, and now they're studying lixisenatide for Parkinson. So we do know from the class that there is effect on the nerves, and it's a positive effect on the nerves. So this is something else that you're seeing with these drugs. And so am I concerned? Yes, I'm much more concerned of obesity. I think obesity is a terrible disease.
There's a question. There's a question someone had. If someone complains of GI side effects, nausea, vomiting on the injectable, what are your thoughts about changing to an oral GLP-1 agent? Will the symptoms improve? Anybody have an experience with that?
Generally, the symptoms will not much improve. Usually, the difference is reduce the dose. So if somebody has it on a 0.5, and going to 0.25, which is not considered therapeutic, will not do much. So that's when you can go to a 7 milligram of the oral semaglutide versus, and maybe they will have less impact, but then the weight loss will be by far less. So that's very important to take into account. I see Peter Jones, hi Peter, is asking something about the impact of GLP-1 on fatty liver disease by its names, whether it's NAFLD or MASLD, and should GLP-1 receptor agonists be purely used for that? It's not approved for that. In their studies, they failed, but they studies managing MASH or NASH in our old terms that was longer than that. I personally see both the GLP-1 and most of the GLP-1 GAP as great drugs to reduce fatty liver disease. The problem is the companies wanted to develop a drug for end-stage disease, like, NAFLD or MAFLD now. and in order to get a lot of money for those drugs. They all failed, except for a recent drug got approval. It's a thyroid based drug, and it has about 20% efficacy. Sure, when you use a GLP-1 on your obese patients, I think with semaglutide, you're around 85% reducing fat in the liver. And for with tirzepatide, with the GLP-1 GAP, we are looking at around 92 to 94% reduction in fat in the liver. So you're correct, great drug for that. It's just not been approved for that, but it's fine. Now, one more thing that we don't know, and that's very important. We don't know if the drug reduces fat from the liver independently, or does it reduce the fat in the liver because of the weight loss associated with that. We don't have an answer for that because no one truly studied that. There are some indirect or some look at patients that if they did not lose a lot of weight, they still have a lot of fat in the liver. So we don't know if it's similarly or not. I mean, it's because they did not lose weight or just it doesn't impact them similarly directly. So we don't know.
Yeah, I think.
What about
Go ahead.
You know, when you presented that case, the triglycerides at time zero baseline were pretty impressive.
Yeah.
Is it unusual in your adult patients, or would you think about the mechanism of that? Is that a single entity? Is it multiplicity? What is it?
Well, I'm a little, perplexed about this lady because, as you can see, she started coming to the clinic in March of 23. If someone, Mandy, you want to put the case presentation lab data back up there? It is slide number 5. And, she came in March of 23. And the first labs that we have are from 8, that we, sort of our intervention. You can see without a statin back in the previous years, she has this phenotype that's quite interesting. And once her direct LDL was measured, we reflex measured starting in our lab back around 2017. So we could see it was low. She almost looks like kind of a type 3 phenotype, but it's hard to know, is this type 3 with a second hit from diabetes? We don't know. We don't have labs from prior to her being diabetic. We don't have that data. So I would say this is probably multifactorial.
Well, the reason I ask is we see some kids with new onset type 1 diabetes who have phenomenal increase in triglycerides, and it's almost like they've depleted all their lipoprotein lipase. At the end.
It's clearly she's got some. Yeah.
Well, she may have a little bit of clearance issues. Usually the triglyceride, because of diabetes or because rather of insulin resistance, it's usually runs at the 240 to 320, 360. That's the number. When we start seeing the triglyceride going to 400 and above, we clearly think that there are other things going on, whether it's a clearance issue, whether it's, lipoprotein lipase, partial, whatever. Yeah, there are a lot of reasons that could be. I love the word multifactorial because it says we don't know much what it is, but that's kind of.
Well, I was hoping you did, but
but
you see the same sort of numbers in teens, particularly once you're obese, insulin resistant. You'll see the triglycerides are usually around 350, the HDLs like 28 to 35, and the non-HDL cholesterol is elevated. You guys
ever
is
this a case of Is this a case of FH2 with superimposed diabetes? She does have French Canadian ancestry. We do have a high prevalence of Franco-Americans, or high population, the second highest in the U.S. behind Lewiston, Maine, here in Rhode Island. So we do have a population kind of enriched with probably FH and other genetic lipoprotein disorders. So that is another consideration. But I do, obviously want to make the point, obviously here was a classic case of someone with a quote normal LDL. And once she had a particle number test, we see this massive discordance, which is common in insulin resistance. Of course, you could say that her non-HDL was going to predict that as well. So,
I'm a little bit surprised that the small LDL number went down so massively, while the triglyceride is still at a 370 level, and she still has insulin resistance. We can look at the triglyceride to HDL ratio. That's a bit perplexed me when I saw her number.
Yeah.
I think we also need to consider, though, that the GLP-1 receptor agonists apparently reduce fat absorption from the intestines. And we see some reduction in free fatty acid when it's coming from there. You mentioned Canada, so Gary Lewis, if you guys know him, he's an endocrinologist, lipidologist from Toronto, and Gary has done some work in that, and he has seen that there is a reduction, also impacts some of the triglyceride. She also improved her diabetes, and she also improved her diet, most likely, to help some of these numbers.
So one of the things that is the goal for us in pediatrics is to be able to get pediatricians and family physicians to routinely check the lipid profile at around 9 to 10 years of age. And the reason I bring this up is because it would be nice to have a baseline before the kids advance into adolescence. And that way, some of these reflective things could be looked back at. And for example, if you're concerned about FH, it'd be nice to know what that number looked like at 10 years of age before age 16, where they're massively obese, insulin resistance, and diabetic. I think it'd help us a lot.
Yeah, definitely. You really need those old lipids. There's some more questions that have come in, and I want to ask the panelists. Why specifically are in these randomized trials, Dr. Wilson and Handelsman, why are non-diabetics losing more weight than diabetics on these agents? That's a burning question. Many people have. It probably has a good answer.
The answer does satisfy many, but not everybody. And it's the only answer that exists. But it's not only for this medication. It's for all weight loss modalities. People that don't have diabetes lose more weight. Even in the studies, in the weight loss studies, where they actually enrich them a lot with people with prediabetes, we are seeing that those that were more advanced prediabetes lost some less weight than people that were with no prediabetes also. So some people are saying that that's because of insulin resistance. And insulin resistance does make it harder to lose weight, and that is correct to a point. But the real and true answer that we believe in, when somebody has an elevated A1C, when the glucose is not controlled, in terms of physiology, it means that the body does not metabolize those calories. Those calories are in the circulation, definitely on an 8 and a 9, but even on a 7.3, because realistically, a person who does not have diabetes and no prediabetes, and if they're not overweight, if we talk an optimal person, A1C should be in the 4th, 6, 4, 7, 4, 8. I mean, if we start to go to 5.2, 5.3 as an average in the population, it's because we take into account the people with diabetes and obesity that causes some elevation of that, just putting it in perspective. So the calories, what does it mean that they don't metabolize calories? Somebody comes to you and weighs 263 pounds. That's a slightly lower artificially than what it would have been had they not have diabetes. And if that would have been the case, the weight could have been 270 or 272 to 73. So the higher the glucose, the more the weight is artificial. And some of you, and I know that Dawn knows that, when somebody presents with totally uncontrolled diabetes, one of the signs are huge weight loss. That's one of the prominent signs of diabetes and uncontrolled diabetes. So in essence, this is kind of similar. Some of the weight loss is actually coming to correcting the weight, and then there is some weight loss. So that's as good as I can tell you. No one really knows about that. And I know there was a related question to a point, does the drug also reduce visceral fat? Probably does, but how the body chooses to place its excess fat in which depot changes from a person to a person. It was not studied. But visceral is the largest depot for fat that we have. So clearly we are going to see some weight loss from these drugs, some from visceral.
Yehuda, does it make any difference if this lady continues her insulin therapy while she's on this drug? Now their A1C is down in regard to the weight question.
Absolutely. If she can get off that insulin, she's going to get another 5-10 pounds immediately off.
Yeah, I mean, that's always been a nemesis for us in the past when we've had to manage type 2 diabetes with insulin.
I will tell you, she's got an A1C of 7.3. There is no reason in the world she should be now on insulin. She definitely has enough insulin because she came down just only with semaglutide from where she was in the 9.8 down to 7.3, which means that she's making a lot of her own insulin. She does not need outside insulin. I would probably give her an SGLT2. Won't give her a lot of weight improvement, but will give her another 0.4, 0.5. Can consider giving, of course, metformin. It's still good enough to bring down the A1C and will make sure she's losing a couple more pounds.
Yeah, because if you look at the American Diabetes Association recent guidelines, they do it on an annual basis, as everyone knows. But now they're really kind of pushing GLP-1s along with SGLPT, whatever that is. Drugs.
Well, yeah.
We recently had those approved in kids, and so we're anxious to see if they're going to also be beneficial for that population. So
it will definitely be beneficial for kids. I tell you, the moment that's a good thing. You have now for kids age 10 and above. You can use a TZD, you can use metformin, you can use GLP-1. I believe you can also use a DPP-4. You have a lot of tools right now, almost like adult, and it would work, and they don't need the insulin.
Well,
I'm talking about the type 2 in kids, just to be sure that we're talking about the same thing.
No, exactly, yeah. And it's an important distinction between that and type 1 for sure. But I think, pediatricians, pediatric endocrinologists, I should say, or diabetologists, I think they, in my opinion, need to get a bit more aggressive with this disease. I think we're a little bit too hesitant to ramp up the treatment regimen, hoping again, as we've been sort of trained, lifestyle, plus some type of insulin resistance. But the go-to has been metformin, and a lot of these kids either can or won't take the drug.
I think you're right. The problem has to do more with obesity, that obesity is not recognized still as a disease, and it's a big issue. And type 2 in kids is just growing, but it's still not to the number that it scares most clinicians.
Well, and what's really interesting is that probably most of the insurance companies that cover children, they won't cover it for weight loss, but they'll cover it for diabetes. So if you can ever reach the criteria that says this child's A1C now is 6.5 or above, or they have an abnormal glucose tolerance test, or whatever it is, then I would encourage people to seize that opportunity. Even in Medicaid populations, they'll actually approve a GLP-1 for that.
So I've got a couple of comments here, especially one that wants to keep us in line with CME and with correct information, stating that in the semaglutide trial, there was a 7% discontinuation rate versus 3%. This would make it 4%, but I will tell you, in the large majority of the long-acting GLP-1 trial, the discontinuation rate is around the 4%. There can be 5% in one trial, can be 6% in another trial, but usually that's what you see. In some of the high-dose tirzepatide trial, you may see a little bit more because it's a little bit of a different of a molecule that you have And we can see that the more important question has to do with muscle loss. And I want to I think,
Dr. Handelsman, I just want to quickly say, I think we're about at 60 minutes, but this is a great topic, especially the lean body mass. If all agree, we can end the formal part and go on for another 15 minutes. Everyone is welcome to stay on. And yes, that question about body composition changes.
I do want to address one comment I think is really, really important. And I want us to for everybody to stay on just for a minute. Can I share my screen with Mandy, with your assistance here? Because I do want to point out that we are not pro anything. We're trying to really make sure that everybody knows the, up and downs of these drugs. And so am I able to share the screen here, Mandy? Or yes, no, yes, maybe? Yes. Okay, I'll try to do this again. And so I want to just point out that we really are needing to, if you can you guys see my screen here?
Yeah.
Okay, in terms of this slide here on cost considerations, that should be in your view there. Can everybody see that? So I want to make sure everybody understands that we're at the, many of us at the beginning of this sort of era where we're using these drugs with, side effects. And so, but we have to think of societal costs here. And, if you looked at the macro picture here, there's 90 million US adults and teens that would meet criteria for these drugs. And if everybody eligible received these drugs, the annual cost, even with the discounts, heavy discounts, would be $600 billion a year. So, clearly we are not trying to say that these drugs need to be, widely used in the population like statin therapy, which is now pennies a day. There was an ICER analysis, and, they really looked at this in terms of, a lot of Markov modeling. It's very complicated, a lot of inputs and so forth. But there were incremental health gains compared to lifestyle intervention alone, earning these drugs a B+ rating. And on the panel, the New England panel, they all voted that this drug had incremental health gains, this class of drug, and particularly the semaglutide. So 15-0. However, the cost efficacy is low, and it would need to be discounted like more than 50%, 45 to 57% to become cost effective in the range of what we consider cost efficacious, which is $50,000 per quality adjusted life year saved. So we're talking about getting these drugs way down to this, sort of range here before we can even think about making these drugs cost effective. They're currently $12,000 to $16,000 a year. So we want to make sure everybody understands that we're not, certainly trying to promote these, and we're trying to present a real broad view of the drugs. That's what I just wanted to say.
I want to point out a couple of things. Somebody that thought that we are too Ozempic or too semaglutide friendly here. We're discussing obesity, and two drugs have shown an incredible impact on obesity. One is called semaglutide, and the other one is called tirzepatide. Until those drugs, even if we looked at the I mentioned before, liraglutide, the weight loss that we got was not that significant. What we have with these drugs now also is not just reduction in obesity, but we're seeing improvement in heart failure. There was just a trial that also was with semaglutide, which was heart failure specific. There is impact on the kidneys and so on, and that's important to understand. Somebody asked what the max we lost weight with those drugs. 25%, some even lost 30%. I mean, that's 5 to 10% of the people that were on that. More on tirzepatide, the dual, less than that with semaglutide. in terms of the muscle, which is important, this is not a drug-specific issue. This is a weight loss specific issue.
Yeah.
The issue, whoever, if you do it with diet, if you do it with oral medication, whether you do it with bariatric surgery, everybody is losing fat and losing lean muscles. We are looking at 60% fat, 40% lean mass. What is the problem? The majority of people then start to get regain, and when they do the regain, it's primarily fat. And then we start seeing a shift in the fat lean mass in the body, and we start seeing the issue that we call sarcopenia, that it's quite an issue.
So I know you know this, but everyone knows this, but in children, a lot of these drugs are not available simply because they either don't have the resources, they're not approved by their insurance companies, even though they may be FDA approved, and they're not covered by Medicaid, which is about, in most people's practice, somewhere between 40 and 60% of their practice, I would guess. And the reason I bring this up is because two things, it lends itself to two things. One is that we're seeing a lot of parents, shouldn't say a lot, some parents that we're aware of at least are going to compounding pharmacies and getting medications that are compounded and giving them to their children. Now, we don't participate in the care of that. We certainly don't advocate it, but we do appreciate them sharing that with us so that we kind of know what's going on. The other thing that you may be aware of, and we've historically had experience with this with insulin, is that parents may be legitimately prescribed this medication and paid for through their insurance, and they'll actually share it with their child.
Yeah, and the other issues, sometimes people used to prescribe Ozempic just for weight loss, and those patients got the name diabetes if it got paid by insurance while they don't have diabetes. So we all have to be careful with it. The whole issue about cost effectiveness and availability of the drugs. We always have to separate the science from the cost and then deal with the cost. Because is the science good? Is it important to lose weight? If I see as 16 years old, or I actually saw patients that were 13 or 12 years old that were already weighing 280 pounds, those people did not have a very good life projection. If you look at a lot of those TV programs and the Big Loser program and so on, many of those people die, and they die at a very young age. So yeah, if we can change that weight early enough to allow them to grow up better, they may live longer and they may enjoy their life better. I have a 24-year-old guy who has been totally almost autistic, we thought. He was so much included with himself. He had a very much high weight. I won't bear you, I started him on one of those drugs. He lost by now about 35 pounds. He is exercising. He is doing everyday exercise. All of a sudden, he started talking. He finished, his university studies and everything. You change people's life when you change them from being obese, especially kids, and when they grow up. So it's very hard to evaluate this kind of money. And I agree with you, money is a big issue because healthcare will get this, cannot pay for everybody. The good news is that they are developing small molecules, oral medication that will act as this will be by far cheaper.
I wonder if you would comment, perhaps, I think what you said I would agree with, and that is that the investment may actually be more cost effective if you started earlier.
Correct.
Right now, our criteria, though, is wait for kids to become, we call it morbidly obese, 99th percentile above. What would be the appetite, if any, for starting earlier with a weight trajectory that clearly says, all things considered, this is not going to go well?
As you know, you can hear me. I'm so much for that. I think it has to be that. And for full disclosure, I was involved in writing guidelines to the American Association of Clinical Endocrinologists on both obesity and diabetes, and we did not go much into the PID world, but we did recommend to start much earlier. in national meeting that we are working, we are very much recommending that to go early, because what you are seeing, Don, you start to see the beginning of a type 2 epidemic in the young kids. And this is just terrible.
And see, what you see in type 2 diabetes in children, just as a reminder, is that most of these kids have at least one, if not two, more comorbid conditions at diagnosis. So they're either hypertensive, they have microalbuminuria, all of them have dyslipidemia. But, understandably, we in science typically start with kind of the worst of the worst in these scenarios. But I think at some point we need to realize that maybe the investment, as you said correctly, and that is, maybe we invest not only in weight loss to help society manage the cost, but we actually make these individuals more productive going forward.
Yeah, again, somebody brings up again the question about lifelong therapy. And whenever we say lifelong, we are all, screaming. But we do know that if people need to reduce their blood pressure, that's a lifelong medication. People know that we need to take your specifically statins, it's a lifelong medication. And right now, some people, and we mentioned FH before, they will need to be on a combination with, with both statins and a PCSK9, and it is a lifelong medication. So why are we afraid when we have to do it for people that are obese? Because we still did not accept the concept that obesity is quite a bad disease that we need to control.
Well, the question sort of becomes, we don't have the experience, but my guess is that there's probably a bell-shaped curve. So you said, I think earlier, that some folks would take medication like this, lose weight, and be able to sustain it for some period of time. Some people may need, periodic therapy to kind of get them back under control. And then some people are probably going to require just lifelong therapy.
Well, I'm actually believing, and I've seen that with diabetes, that I could get people to A1C in the low 5s with diet and exercise and medication. If I kept them for 3 years on that low 5 and stopped the medication, they would stay on that for several more years. So I think that once people would stay on that weight loss for at least 5 years, not less, we know it for bariatric surgery, they have to stay on it on 5 years. There is going to be a sizable group of them that will learn to eat less, that will learn also to exercise more, and perhaps be able to maintain their weight for that time.
No, I agree. I mean, I think, again, one of the things that we're dealing with in children are immature individuals who eventually get to, not all of them, but many of them get to the point where we all did, and that is they want a meaningful career, they want to have a family, they want to do things, and then they embrace the message that you've been teaching them all along. But clearly that's not everybody. But I think that is worth some conversation about being a little more aggressive, I think. For right now, one of the interesting ironies is we can't get the drug covered, and Dr. Aspry explained about the economics of this. It's huge. What's interesting but somewhat ironic and frustrating in the state of Texas, at least, our Medicaid programs will pay for limited dietary counseling, and then they'll pay for bariatric surgery, but nothing in between.
Right.
Well, hopefully that will change, with these drugs. And also there is a bill before Congress on Medical Nutrition Therapy Act that's been reintroduced in this 118th Congress that is going to hopefully, if passed, expand the indications and allow Medicaid and CMS Medicare beneficiaries to receive dietary counseling by RDNs outside of just having diabetes and CKD. So, these things take time. These are big policy changes that are big levers in the population. And so if anybody's into advocating and speaking to their lawmakers, you might want to go on. We can give you information about this and how to send some message to your Congress people.
Actually, they're also holding a meeting right now on examining why the drug companies charge that much money for those semaglutide and tirzepatide. So that maybe that will take us somewhere. We'll see.
Well, listen, Ed, I think that this has been a great conversation. We still have so many questions left, but I'm glad that we hit upon most of the pertinent issues. I think based on this response and the questions, we can go back to NLA and see if we can have a part 2 to this session. It's a evolving story as well. So I'd like to thank our panelists, Dr. Wilson, Dr. Brink, Dr. Aspry, and Dr. Handelsman. And on behalf of myself and Dr. Mintz, please feel free to write in, let us know your thoughts and how we can continue this very important conversation. But thank you all for joining us, and thank you for our panelists. Very good and informational evening.
Right. Thank you all.
Okay.
Thank you all. Bye-bye.